What I've been doing over the last few weeks is I've actually been really diving into the medical literature on SI joint pain and dysfunction. And I've only touched the research of it previously. And I don't know, I just got that bug where I really felt like seeing what the medical literature had to say about it. Because in my experience, SI joint pain, I have never found it there ever to be an actual problem with the joint itself. It was always solvable relatively quickly with work on the muscles. And so I was very curious to see what kind of the prevailing medical paradigm had to say about it. So I really dove into the research, and I'm going to be preparing some more formal articles and videos, a series about this. But I just thought I'd touch upon some of this stuff and give you a preview. So basically, reviewing the medical literature, the SI joint is an extremely stable joint. It has very limited ability to move. It is a synovial joint, so it does have synovial fluid. But in the scientific studies, it only can move in millimeters. 2 to 4 millimeters is general. And then it can only move 1 to 4 degrees of rotation. But even then, it's baffling to most medical people, SI joint pain and dysfunction. They always think that there is a problem in the joint and that there's too much laxity, it moves too much, it's unstable. You hear that a lot. You hear that a lot in the yoga and corrective exercise and PT and ortho world, that your SI joint is not stable if you have pain there. And you people that are CTP members know that our take on this, it's almost never a problem in the joint. And that's backed up by the pain clinic studies as well. 82% of pain presented to clinics where the medical practitioners actually understand trigger point therapy. 82% of people coming to pain clinics are diagnosed with myofascial trigger points as their primary pain source and treated very quickly and with great success. Even using the old school methods, injection and the old Terrell and Simons type methods. So it's basically the joint itself has irregular surfaces to it, and it's extremely stable, extremely small, and it's basically like a cushion. It's a little tiny shock absorber that basically helps transmit forces from the upper body to the lower body. And it is supported by some of the strongest ligaments in the body. The thing that turned me on to doing research on this was a yoga teacher, like a trainer, like an anatomy expert, telling me that the joint can rip apart. And so I had to dig through the science to show her that no, it can't rip apart. In fact, from the cadaver studies, you need 400, 500 pounds of force per inch to actually change the spacing of the joint. And basically that's enough force to break the sacrum or break the pelvis. So that would only really occur in a high impact collision, say like a car crash or something. So to change the spacing manually of that SI joint, it takes a lot of force, and you can't do it through regular movement or exercise stuff. You just don't generate that type of force. It's not possible. According to orthopedic doctors, these are the common symptoms: low back pain, also pelvis and buttock pain, lower extremity pain in general, hip groin pain, problems sitting, sleeping, or walking. So those are very general. And in terms of trigger points, I don't know, can anyone tell me what are some prime suspects that would generate these types of referrals? Anybody want to throw that in the chat? Even one? Yeah, exactly. Glute medius will refer right there into the SI joint area, sacrum. Glute minimus, of course, we know the sciatica muscle sends referral down the leg. We got piriformis, iliopsoas. Yep, iliopsoas has a vertical pattern and can go over the SI joint area. Yeah, that's pretty much the list. No one. Oh yeah, someone said. Yeah, Stephanie said QL. QL is a prime suspect in all of this stuff. Hip groin pain. Okay, so that's the trigger point understanding of it. So here's just a couple things from the medical literature that I found very enlightening. They did movement studies where they were able to measure these really small movements with a technique called RSA. And they use these little beads that are like less than a millimeter, and they actually implant them into the pelvic bones. So, according to these studies, they revealed that nutation, which is it's like the forward rotation of the sacrum, nutation occurs when patients loaded their spine by means of rising from supine towards a sitting or standing position. And the authors demonstrated that the movements do not differ between the symptomatic and asymptomatic sides. So if someone has SI joint pain on one side and not on the other, the movement of the SI joint didn't have anything to do with that. So I thought that was very interesting. Another study here, this is a little kind of medieval, but for people that have really intense pain, they actually use this device called a Hoffman status frame, and they actually attach it to the pelvis. And what they think that they're doing is stabilizing the SI joint, and then that will reduce the pain. But then what they found out when they actually measured the movement of the SI joint, that there wasn't any change in the movement. Nothing changed with the movement of the SI joint, even with this contraption. So the manipulation did not alter the position of the sacrum in relation to the ilium. The results seem to indicate that effective manipulation is not dependent on positional change of the joints. So people would get some relief from this stabilization, but it didn't do anything to the joint. It didn't change the joint in any measurable way. So this just, to me, it looks like what we can just say, what is it doing then? What is it stabilizing if it's not stabilizing the SI joint? To me, it's stabilizing the lumbopelvic hip complex. It's stabilizing your lumbar spine and how it's working with the pelvis. So it's helping your QL muscle. So I thought that was very interesting. Also, there's like a handful of orthopedic tests that are generally used as part of the diagnostic evaluation for SI joint pain. And in the medical literature, all of the high quality studies showed that they weren't very reproducible, and that they were not good diagnostic methods. And so some of them are provocative tests where basically they will produce the pain if you do the test, and that's a positive for it. So here's one of them called the Faber test. And you can see it looks suspiciously what we would call the figure 4 test. And so this is the person's leg is abducted and externally rotate a little bit, and then they push the leg down towards the mat. So what do you guys think could be happening here in terms of muscles? Like what muscles are being lengthened or shortened in this that could cause pain referral into the SI joint? Throw it in the chat. Pure form is shortening. Yep. Yeah, yep, glute medius, lengthen adductors. So the big thing that comes to my mind is the glutes. You're really bunching up the glutes. So they're going into a shortened position, and that could easily cause this test to be positive for SI joint pain. And that's probably what's happening in these tests, since the actual joint spacing is not being altered and really can't be altered by these types of movements. So we're probably looking at the biggest suspect to me would be like a glute medius going short. And then also people often will get the glute minimus referral here as well. They might get some sciatic type symptom down the leg, in the thigh or in the lower leg. So that's one test that is not very actually helpful in determining if your SI joint is dysfunctional. You're probably testing glute shortness. And there's the referral picture for glute medius. The referral goes right to the sacrum. It also goes into the glutes and can come up above the iliac crest in the low back area. Here's another one. This one is called the Gillette test. And so this is, a lot of people use this, chiros use this test, and they try to actually measure the movement of the SI joint and then compare it from side to side, like the side that has pain and the side that doesn't have pain. And what the actual studies did when they did careful measurements was that the results showed that there were minimal changes of movement in the SI joint. Like, it didn't really move very much. And there was no difference in the movements between the symptomatic and asymptomatic sides. And then what they said then, the study authors said that patients are physically challenged, leading to bilateral increased force closure of the SI joint. So they attribute it to they attribute the pain provocation to be still at the joint because of increased force closure. So that's what they're still hanging on to, because they don't understand trigger points, is that there is some type of force operating at the joint, and that force is making the joint doing something to the joint. Even though the assumed SI joint motion during the test doesn't actually occur. And the authors conclude that movement of the external pelvis relative to the hips gives the manual illusion that the SI joint is being repositioned, but it's not. And so this is where somebody like stands on one leg, and then the other leg, the contralateral side, they flex the knee at 90%. So that's supposed to put movement into the SI joint then, and that's supposed to be measurable, but it's actually not. But somebody could get pain during this, usually on the standing leg. And so what do you think that could be from? Go ahead and put it in the chat. What muscles are getting stressed by a one-legged standing? Yep, glute medius, glutes again, QL, exactly. Those are the big ones, glutes and QL. So that's probably what's happening in this test as well. And that's where the pain is actually coming from. It's coming from QL or the glute referral. And there's the glute medius picture again. Here's our QL referral. Notorious, goes right into the SI joint. So I actually did that Faber test that I showed earlier. I just laid down on the floor and did that 10 minutes ago. And I got SI joint pain when I did it. So I guess my SI joint's dysfunctional. Yeah, that's the funny thing, is when I'm doing I do provocative things in my own like yoga, my own maintenance yoga program that I do for myself every day. And I often get like little nigglings of SI joint pain. And to me, that's a good thing, because I'm doing things that are stressing the stabilization, especially the QL and the glutes. And I'm doing things to strengthen them. And then I also often do like a contract, relax, stretch as a resolving thing. And I sometimes will then get some of these referral pains, but it's not like something that lingers or lasts. It's like just something that I get when I seriously lengthen or shorten these muscles. So I'm kind of provoking that by bringing out the referral patterns. That's part of my own kind of self-treatment, is keeping these muscles healthy by making getting these trigger points to actually resolve and doing things to actually minimize them. Let's see what else. Okay, so the other big myth with SI joint pain is with pregnant women. There is a relaxin hormone that loosens ligaments, prepares the pelvis for wideness, being wider during childbirth. But what the actual studies show in terms of SI joint pain with pregnant women is that pregnant women with moderate or severe pelvic pain have the same SI joint laxity, the same amount of space and movement in the joint as pregnant women with no or mild pain. So it's the whole thing again, blaming the joint when there is actually no correlation there. I think probably what's happening with low back pain and SI joint pain with pregnant women is that, hey, they're suddenly carrying a lot more upper body weight than they were before. So and they're actually being challenged with, their spine is going to be getting more like lumbar lordosis by the nature of the pregnancy. So that's going to be shortening the QLs and putting more stress on them to stabilize. So probably it's the same story. It's probably the primary players are glute and QL referral. And did my sister-in-law, actually, I treated her when she was pregnant for SI joint pain, and she had a significant leg length difference. And I did the trigger point work on her, used the lower body protocol like normal, and set her up with the heel lift, and that went away right away. So that's my experience. The other thing that I found interesting, and this is my last slide here, is that they attributed a leg length difference as being something that contributes to this SI joint dysfunction. So they said a dysfunctional SI joint is normally not related to a subluxed position of the joint, but to increased or decreased compression force closure due to asymmetric forces acting on the joint. So again, they think it's just a matter of the forces acting on the joint, and the joint's having problems stabilizing. And they did a finite element modeling that that showed that a leg length discrepancy as small as 1 centimeter increases the load across the SI joint 5-fold. Not only they're going to keep saying that the SI joint, the load is increased because of the asymmetric forces, but we know as trigger point therapists that it's increasing the load, that asymmetry is increasing the load in the whole lumbo-pelvic hip complex. It puts a lot more challenge into your glutes and your QL particularly. So again, they're probably looking at trigger point referral, but they're going to keep talking about it as joint force closure. That's it. That's my preliminary research into it. So I plan to do some more stuff and put out some more videos and articles on different aspects of this and explaining it more in terms of the trigger point referral. So there you go.